everyone, thanks for checking in. So it's been a while since I did my video. I just finished my final exam for my ICC clinical clerkship, and if you don't know what the integrated community clerkship entails, please check out my previous video where I talk more about exactly what it entails. But yeah, it's been a while since I posted a video and really focusing, trying to embrace the principles of deep work and digital minimalism. And if you haven't checked out those excellent books by Cal Newport, I highly recommend you check those out as well. But this would be a very opportune time just to sit back and reflect on kind of my experiences, what I've really enjoyed, kind of my struggles that led to significant growth, and just some thoughts about medicine and clerkship for anybody who's going through that experience. Because it is kind of like a dark hole. I know for the first 2 years, this is kind of talked about how the term, it's kind of the rite of passage to become a physician. And it most definitely is very challenging, but also is very rewarding and very fun. The integrated community clerkship, as I talked about in my previous video, was everything kind of I expected to be. It is very challenging. It is, I would argue, more difficult than the traditional clerkship in many ways, just because you're bouncing around so much between different things. You're really having to be in a new environment almost every week or every second week. You're constantly trying to learn. You're always feeling at the bottom of the totem pole, and there's this non-linearity. So as I tell you, by the time you hit December, you've done 6 months of clerkship, you're working your butt up, but you feel like you know absolutely nothing. And then you kind of hit that critical period, like late December, early January, things start to really click together and things start to integrate. That's kind of the whole point, and that's how the first 2-year curriculum of UBC, I'll call it the spiral curriculum. Before it used to be done in blocks. And that is valuable because you do get to build steadily one top the other and you get more in depth. But then after you do that block, you never come back to the information. So the whole idea, I think it's pretty well worked out in the educational literature that the more you come back to material, the more you repeat, and spaced repetition is a very important principle of long-term retention of material, really improves learning. And that's the whole idea of taking this spiral curriculum that's done in the first 2 preclinical years and applying it to a clinical clerkship. It's definitely not for everybody because there's a lot of non-linearity. You go 1 week in obstetrics, 1 week private practice, 1 week emergency, 2 weeks general surgery, 1 week psychiatry. It can be quite overwhelming as it's totally different. But what I really enjoy about it, and I think Chilliwack is kind of the perfect size, and depending on what your interests are, I've always been really fascinated with family practice. But what I love about Chilliwack is, even though it is really classified as a rural community, although it's starting to transition to more bigger center, 90,000 people live in this. It's a nice small community hospital. I really love you get to know everybody, know all the doctors, know all the nurses in the OR, most of the nurses on the wards. You see kind of the same doctors, the same patients, you work with the colleagues. It's a very sense of community where even if you go to Abbotsford, which is quite a significantly bigger city, but still not what you call an urban city area. It's more in kind of a rural-ish area, farming community, but quite expanded. You don't get that same feeling. It much feels like a bigger city hospital. You don't really tend to know everybody. Everybody just comes in. There's all over the place working their jobs. So it's a different vibe. Both have their pros and cons. But what I love about Chilliwack particularly is you get that community feel, that continuity. I get to see patients. But that was the coolest part I really enjoyed is that was anesthesia. I do a pre-anesthetic cult with a patient. And then when I was on general surgery the next week, I would be in the OR for that patient. And then we'd follow up with that patient afterwards the next week with general surgery as well. So it's really cool to see that continuity of care, which is very rare in the traditional model where you're in blocks. Sometimes you get lucky, but it's kind of hard, especially when you're thrown all over the lower mainland versus being in the same hospital. As well as that everyday family practice where I really go again, you get that continuity care. You see patients multiple times. What's really rewarding is when you discuss the patient about smoking cessation, about incorporating exercise into their lifestyle, or improving diet to help better control their hypertension, and you see them 2 months down the road and then made those changes, and you can have that talk and you said, oh, what you said here made sense, and I was able to incorporate this, but having challenges with this, and you kind of, it really does an excellent job of selling family practice. And Chilliwack is such a cool, unique place in British Columbia. It's one of the few places, it's a vestige, where the family doctors are allowed to still see their patients in the hospital. Yes, it is more challenging. It makes life slightly more, you have to be a bit more organized and be more flexible and adapt. But I really do believe it improves patient care. But it is imbalanced, especially in this world as the cities go bigger and bigger. Because in Chilliwack, it is so nice. And again, another aspect I love being in a community hospital. You do a lot more call, a lot of specialists, which is great because you get a lot more hands-on. You're always one-on-one with attending, which is something that's so rare, especially at our stage. But we get every attending. And you can look at it and say, oh, it's a negative because you're really under the spotlight. But I think that's the best way to grow. And I love it because then you're getting that feedback and you really get a lot of opportunity to be independent and get your hands wet, start doing interventions, which is so cool because you don't get to the bigger hospitals because there's so many other learners. You're not going to get to do IVs after IVs or practice intubations and really develop these skills, which is the time to do it. So I love that when you're on these calls, physicians, you're in the outpatient office, everything's so kind of close together, small community hospital, oh, emergency calls the gen surge office. Oh, we have a patient for you to see. Well, he'll just send me off. I'll kind of trot over quickly to the hospital. Take me 5 minutes, see the patient. He'll come in about another 20-30 minutes after I'm done my consultation. And then we go make our plan, do the appropriate management, and we go back to the office. And I just love that, which is much harder to do if you're in Vancouver and your office is a 25-minute drive. It's not feasible to be relying on the physician to go in from his office, back to the hospital, etc. So you kind of lose that feeling. It's a different practice, and I think different strokes for different folks. There's no perfect system, and each have their pros and cons, but it is very cool seeing this system, as I haven't really been exposed to it a little bit by one of my family practice preceptors in my first year, who was a family physician and also saw his patients at Lionsgate Hospital. But there was another interesting thing my site director talked about again, which was one of the pros of an integrated community clerkship, or what some people call longitudinal integrated community clerkship, is that they found that third-year students had a much less decrease in empathy than typical traditional rotational clerkship. And you might, hold up, we're being happy because there's a less decrease in empathy, but unfortunately, it's kind of the system we're in, and I think the next phase of improving physician well-being is a big focus on kind of training these kind of softer aspects, such as empathy. Now, no doubt some people are able to be more empathetic and are more finely tuned with these emotions than others, but I don't think it's 100% purely genetic, and there are ways to actively reinforce them. And that was this I talked about in my previous video about the top 5 books every medical student should read, about the excellent book Attending, and kind of the impact of mindfulness and how it reduces burnout, also improves empathy. And I think with in clerkship, it's such a beautiful time. It's so hard, you're so tired, but it's really, I remember talking about the residents early on, I was kind of feeling a bit down, I had a tough gen surge rotation, and just really not feeling confident in my abilities, and that happens a lot, especially in the ICC program. You feel like you're riding high, you're doing well in this rotation, you go into your next rotation next week, and you feel like a complete imbecile, don't know anything, and it's about this constant cycle of feeling like nothing, and you start to kind of grow, develop skills, and you go into a whole new field. It's almost this magical metamorphosis where you go from this fresh-eyed, bushy-tailed third-year clerk that knows really nothing, is totally naive, to start learning about the system, really understanding how the different moving parts work, and you really gotta help patients, and it's so rewarding taking that theoretical knowledge and applying it. But on the converse side, when medicine is theoretical, it's so nice and clean and pure. Someone has high blood pressure, this is what you give. You recommend low-salt diet, you recommend eating healthy foods, a DASH diet, lots of green leafy vegetables, etc., etc. When you get into the real world and you realize there's these complex social issues that underlie the medical issues that patients come into, and also the biopsychological model of disease, where it's not just the biological pathology, but also the psychosocial component that comes into it as well, which can be overwhelming and frustrating at times, where we're so trained and we're focused on the medicines and the evidence-based and making great drugs. And I think that's amazing. That's great. We're doing this. We're not naturopath or homeopathy. We're just making things up and we're relying on placebo effect, which is fine to a point, maybe not ethical, but that's besides the point. But I think we've lost something where we're so interested in this, in evidence-based, where we're trying to learn everything, be right, be the smartest physician, know everything, get the right answer for our patient. There is incredible value of just developing that therapeutic alliance, even if you aren't able to help that person, or even if there's a huge social issue that you can't fix as a physician, or way too complicated, such as addiction, homelessness, poor access to food, domestic abuse, physical abuse, sexual, all these huge issues that happen outside the clinic or the hospital that you can't really influence. And it can be kind of overwhelming. You see so much suffering, you see patients that you aren't able to help, and that can be quite demoralizing. Or it's hard to see patients die, or hard to see patients suffer unnecessarily, or patients in a lot of pain, intractable pain that you can't help. And that's kind of the good and what makes medicine such a privilege and a rewarding field, where you can help these patients, but you aren't God. You can't fix everything. And it's a very humbling field as well, because you may know a lot, but there's so much you don't know. And I think that's why you get the Dana-Kruger effect, where it's the blind leading the blind, because the more you learn, the more you realize you don't know. And I think it's kind of interesting in medical school. I feel like the further you go in medical school, the less confident you get, because as you amass more and more information, you start to push the boundaries of your lack of knowledge, and you push your boundaries of knowledge, and you realize, wow, I learned so much, but now there's 10 other things I need to learn for every one thing I learn. It's like a never-ending cycle of learning, but that's also what makes it so beautiful. But again, coming back to that point of empathy and decreasing empathy, I think it's so important. And it's very easy to lose and get burnt out. And I think, again, that happens in cycles. I mean, our set directors, everybody gets burnt out at one point. You push too hard. I think that's a good balance and a nice time to learn in third year, especially in the ICC program, because there's so many opportunities and it's so easy just to say yes to everything because you want to help, you want to learn. It's so exciting, but you have to learn to realize, okay, when is the time for me to take time for myself so I can come back refreshed and bring my best self to my patient's hospital, so I'm not overgeneralizing or kind of making rash judgments without fully understanding the patient or losing that vital empathy. I think that's what's really cool about the ICC program. I mean, obviously, you learn so much. I mean, everybody's going to learn the same. The whole idea of medical school is we want to get doctors to be the same once they graduate. I think that's kind of another mistaken notion, just lay audience, or people coming into medical schools, they think that medical school is going to train you to become that ophthalmologist or anesthesiologist. And they'll definitely give you opportunities to learn about the specialties, but really the goal of medical school at the end of the 4 years is to educate and create a well de-differentiated physician that can really go into any environment and be competent and have a good general approach and know how to triage things. And then that's why you have your residency. So if you want to do anesthesiology, which is super cool, that's my own bias, then you do 5 years of residency plus or minus 2 to 4 years of fellowship afterwards to learn that specialty. But you have the foundation of being a well-rounded, de-differentiated physician. And regardless of what specialty you go to, even surgery, just joking, you still need to be empathy because you need to communicate. Even doesn't even matter if you're in pathology as well. You're just communicating with physicians, and you're still going to have to understand how to communicate, because that's really the crux of any effective system, and including healthcare systems. Poor communication universally leads to bad outcomes. And I think what's really cool about the ICC is working with the attendings. You see all the different personalities, the effective ways to be empathetic, whether that is through their communication style, whether it's very brief, whether it's a bit like they take longer, etc., how they communicate. It's very, I think that's one of the biggest takeaways I take, not mention just the medicine, seeing all the cool things, getting assist with all the surgeries, getting in with anesthesia, helping do the intubation, do the peripheral nerve blocks, do the IVs, etc. You get to see how different physicians deal with kind of the challenges and the beautiful aspects of medicine simultaneously. I think Clerkship, integrated community Clerkship, I can't recommend it enough. I know it's not for everybody. If you really do like stability and like kind of the same thing and you learn very sequentially, linearly, I think most people do learn better that way, but I think there's a lot of value in really challenging and pushing yourself to kind of take things. So I think the next wave of physicians, as things get more and more complicated, it's too easy to get lost in the minutia. And I think, especially I find, unfortunately, with the USMLE, I flirted with taking that just in case I was going to do fellowships in the States after I do my residency training here, because in Canada it's more robust. Because, for example, in anesthesia, it's a 5-year program, but it's 4 years in the States. So if you only, because they do an extra year of internal medicine, as of right now, in Canada versus the States. So if you do your residency in Canada, you can go to the States, get board certified, and start practicing. But you can't come back to Canada if you do your residency in the States unless you do that extra training, that year of internal medicine. So really, the doctors in Canada are trained better. It's more robust. There's less of that business aspect about making money. It's more about best patient care, and that's why, the orthopedic surgeon we have in Chilliwack, he's an absolutely amazing orthopedic surgeon, but he did his fellowship in the States. He talks a lot about, you have to be careful interpreting a lot of these studies from the States, because a lot of these hospitals, a lot of surgeries are done unnecessarily because they get hospitals, they're profitable surgeries to be done. They still get good patient outcomes. They're never going to do surgery that's going to make worse patient outcomes, but they're way more biased to promote surgical interventions because the hospitals run like a business instead of here where it's run as a non-for-profit. The hospital isn't trying to make money, it's trying to manage costs. And at the end of the day, if you can get the same outcome with a non-surgical intervention versus a surgical intervention, it's way better for the patient. Yes, I think anesthesia is so cool, it's amazing how great it is, but at the end of the day, there's still risks for any intervention you do. So if you can avoid an intervention, that is definitely a huge plus. But with this ever complicated, increasing complicated, excess knowledge in medicine, the ability to integrate and understand is so important. And I think you lose that by just about regurgitation and about taking these things, doing your 6 weeks, blasting it on your exam, and then forgetting about it. And that's why I love about integrated community clerkship and this exam, because it's really reminding of, and it's great preparation for our LMC, kind of our licensing exam, where it's everything at once, because our peers will do, let's say, brain and body block, which is internal medicine and psychiatry, and then they write their 6-week block, and then they never touch internal medicine and psychiatry again, which, again, practicality, it makes the most sense. But an integrated community clerkship is definitely harder to organize, and it's amazed by the staff we have, the staff who runs integrated community clerkship, organizes everything, because absolutely she's amazing. and the site director just organized, and the way they allow us to shuffle between different specialties, is such an amazing experience. I know they're trying to expand it, and you get a different feel. Like being in Chilliwack, so close to the city, you can do electives closer to the city just to get maybe more specialty if you're interested in it. Where you kind of lose that, like if you go to the further north, like Terrace, for example, I believe is mostly run by family doctors, not as many specialists. So you get a different vibe when it's more family doctor versus not. But it's really cool seeing kind of the breadth of practice you can get as a family doctor in a less urban setting. But yeah, I just wanted to kind of take a step back, reflect on my experiences during third year clerkship, kind of just talk about different aspects of medicine, and just all the cool things you learn about the positive and negatives, because it is more difficult, but I think it's difficult in a good way, because you can have things that are just more difficult for the sake of being difficult, which I think is useless and just not helpful, versus things that are more difficult, they challenge you, help you grow, help you integrate things, and that's why it's called integrated community clerkship. And I love that sense of continuity. Different strokes for different folks, right? That's why some people don't like family medicine. They don't want to see the same patients over and over again, and that's kind of really important to understand. And I think that's so important. Just a quick segue on specialties, because now we're coming to that period where we're picking our electives, kind of determining future career plans, planning in terms of how do we want to do electives, where are we going to apply, etc., etc. And yes, honestly, I think every type of medicine is cool. I haven't found an area of medicine which I didn't think was cool. Doesn't matter what you do. I think that when you see the skills, the competency, how much all your attendings help patients, is just amazing. But you have to understand, okay, how do I want my life to look at? Am I going to get married, have kids? Am I not? Whatever. Different strokes for different folks. Do I like the people I work with? Do I like the personality of the search? Because there are stereotypes, and I wouldn't say stereotypes, but there are certain personalities that tend to go to other things. If you're a very go person, you like kind of constantly doing different things, then that's perfect for emergency. But for me personally, I don't like the non-linearity of emergency, even though I think emergency is cool and I can see it as being rewarding. And obviously it's one of the most challenging jobs. Like I am so in awe of my colleagues or anybody else who does emergency room, because they do it so well, and I think it's so difficult because you really have to be an excellent diagnostician in very little time, very little information sometimes, not very great stories, and you just got to make really important decisions. And you're really at the front, and there are a lot of acute life-saving stuff, which I think is really cool. But then the hardest part of emergency isn't when someone comes in with a really acute crash. I mean, it's very difficult to see, and you want to do your best, and you don't get good outcomes. But at least it's very clear, if this is emergent, we got to do the best we can. We have our tools, we have our routine, we give our pressors, etc., central lines, all of the certain interventions. What I think is much scarier and kind of hard to distinguish is the really non-acute, non-sick patients that don't need to be in emerge, versus the kind of hidden, grumbling, really scary, kind of unusual presentation of an MI, or an unusual presentation of a perforated appendicitis. That's really the challenge of emergency medicine. And you're just all over the place, and I think some people love that. And I think you got to realize, okay, you can love the medicine, but do you love the way the work is? Do you love the shift work? Versus with anesthesia, I think what's really cool is you do one thing at a time. You're with one patient. You control your workspace. It's very kind of linear. You kind of go through your day. It's very varied. So it depends on what you like. It's same with family. Like, what do you like about family, etc. Like, do you like seeing the same patients over and over again? Do you like the continuity of care? Or do you like being a consultant, seeing many different people, and then being able to discharge people from your practice? And I think doing that integrated community clerkship, I think it's really cool, because you get to see different specialties at different times. Because I think at the end of the day, any specialty you do at the beginning, it's not as enjoyable because you're so incompetent. But once you get really competent, things are really cool. And it's really cool seeing different people at different phases of the year and different preceptors, because it gives you a much better sense of kind of what the flow and kind of that specific specialty is. So obviously I'm totally gushing about how amazing ICC is, but I just wanted to reflect on kind of my whole third year. I haven't been doing a lot of videos on it. It's been very busy, and I just haven't had the time or the interest as much to do it recently. But I really wanted to kind of share this and kind of just get off my chest, talk about all the cool things that happened with Clerkship and kind of what to expect for all those you have it coming up. I mean, it's always taken as this really scary thing, and they are definitely challenging times, but it's really an amazing time. And I can't speak for other schools, but I know at UBC there's a bunch of support. That's another thing that's great about the ICC. It's such a small program. I love that one-on-one support you get. You feel really connected with your peers. It's a very different vibe than being in the Vancouver Fraser medical program. There's over 250 of us, or whatever, 200-ish. I don't know the exact number, but quite a lot of us. So you do feel like just a number, where here you actually feel like an individual. You know site administrator, you know, your site director. So that's really cool and very nice. But yeah, I mean, there's a lot of support, but it is definitely challenging. You definitely will have different preceptors. Everybody has different personalities. Again, different strokes for different folks. You may not totally vibe, but at the end of the day, you're trying to become a professional. You have to be professional about it, respectable. And there's a boundary too. Someone can be tough on you, maybe not be the nicest. And you got to determine for yourself what that fine line is between someone being gruff, passive aggressive, or them having a bad day and taking out on you versus them crossing the line. And I think it's important though that if you feel that is being done, you discuss with someone, debrief. It doesn't mean you go and report them, because I think a lot of times you have to take things in context. People have bad days, but I think it's important to realize that boundary. I think it's really important. Yes, you are at the bottom of the totem pole. Yes, you feel kind of, and sometimes you get disrespected, but you shouldn't be demeaned. You are a valuable member. And I think that's starting to change, and people start to realize you are colleagues, and it feels very nice, especially when you feel like sometimes you're just kind of slow on your preceptors, where they really appreciate your help. They really validate you because they know that they were in their same position. I think there's two ways to kind of take this, and it's interesting. It seems like a lot of the older physicians, they were treated very poorly, and for some reason they think, oh, because I had to deal with this, you should have to deal with this. Which I guess that's their logical thing, but to me it just doesn't make a lot of sense. He's quite immature that just because you were treated badly. I know for myself, when I've had really negative experiences in the OR, for example, I know if I was ever a surgeon, I would never treat my medical student like that. And I think that's starting to change, where you see the new wave of physicians. And there's no qualms. Being tough isn't an issue, or demanding excellence or greatness isn't an issue. We should be demanding, but there's a humane way to do it with empathy and being reasonable versus in a way that's degrading and putting people down. But I mean, I've had no experiences like that, thankfully, at UBC. I mean, it is challenging though, because especially when it's 3 o'clock in the morning, you're in the OR, it's a tense situation, the patient's not doing well, things kind of get a bit hairy. But you have to realize at the end of the day, everything it's not personal. It's about the best thing for the patient. It's tough, but it's so much fun. So I really hope you enjoyed this video. You hope you enjoyed kind of me sharing kind of my third year clerkship, kind of some lessons I had, kind of my experience at ICC, the pros and cons, why I think it's super cool. And I really hope you enjoyed this video. If you did, please give it a big thumbs up, and make sure to subscribe to continue getting more awesome videos, and check my website to sign up for my newsletter so you don't miss out. I'll talk to you soon.